Okay, so I'm going to introduce our next two speakers. And I just want you to know why we have this topic. I am a listening spoken language specialist. I have taught many children that are deaf and hard of hearing to hear, and many of them to speak. But there are some children that have other issues that makes speaking not an option for them. So looking around to say, I got the information in, how can I help this child communicate back? And that is where I feel like these next two speakers are going to give us an option as either a family member or a professional to look at, so that when we know that the information is going in auditorily or through listening, how can we get them, the child, to be able to communicate back to us? So I would like to first introduce our first speaker. It's Jason Dwyer. He is a SLP, or speech language pathologist, and he's from the Children's Healthcare of Atlanta, or CHOA hospital. He received his bachelor's degree in communications disorder from the University of Massachusetts, his master's of arts degree in communication disorders from the State University of New York. He is a speech language pathologist, assistive technology specialist at Children's Healthcare of Atlanta, or CHOA. He evaluates and provides treatment for children in outpatient and in inpatient settings with assistive technology concentration. He conducts evaluations for children needing assistive technology equipment, including bedside AAC, which is Augmentative Alternative Communication Assessments. Jason's programs AAC devices and educates family about equipment use. He is a clinical instructor providing AT in service and community trainings, and collaborates with community professionals. Again, I would like to introduce you to Jason.
All right, Jason, we're going to stop sharing our screen, and then you can start sharing your screen.
Perfect. Thank you guys so much.
I'll tell you when we see your screen.
And now, just to,
No.
How's that?
Yep, looks great.
Gorgeous. All right. Well, thank you guys so much for having me today. I'm really excited to be able to talk about this. Like they said, I get to do this each and every day, and I'm super excited about presenting it. You guys already did an excellent introduction, so I don't even have to go over this, which makes it much easier for me. But again, I am a full-time speech therapist and assistive technology specialist at Children's Healthcare of Atlanta. And I work primarily outpatient, but I'm also contracted inpatient for consults across the entire CHOA setting. So I'm, an inpatient, meaning day rehab, and then outpatient at the different locations. But today, what I wanted to cover for you guys was some common AAC myths. The AAC evaluation, I tried to break it down into 3 areas, that being the background information, the assessment, and then recommendations. And then at the end, I'm going to provide you guys some resources that will hopefully help you guys in going home and applying some of these ideas and being able to work with your students. So the first common AAC myth I want to cover was that AAC will replace a child's voice and should be the last resort. And so this is obviously a myth, and there's so much research out there already, but so research for years by years has showed that a child's speaking ability will either stay the same or it'll increase its vocalizations with the help of assistive technology. And some of the ideas behind that is that with the speaking device, that they get to have that auditory input whenever they want. So there's no having to rely on communication partners to be able to repeat something over and over. Additionally, with that, having a speaking device, there isn't any kind of pressure of a communication partner saying, say it, say it, say it. I always explain to my families that, it's kind of like when you're on stage and it's obviously very difficult to talk in front of people. And if you're on play or on stage, whatever it is, it almost feels like that bulb is getting bigger and bigger when you say it, say it, say it, come on, do it. And if the child could do it, they would do it. Not to say that they won't be able to do it, but putting more of a spotlight on them and putting more pressure on their system that's already pretty heavily pressured in terms of themselves, that's not going to help them in being able to communicate. But giving them a voice output with a device, that's going to help them in having no pressure. And then they can also hear it whenever they want. Additionally, it's also just impossible to predict the future. You know, no one can say that someone is not going to be able to talk, or someone's you know, going to be X amount of years before they talk. No one has a crystal ball. And so what I always tell my families too is that, again, we are not trying to replace anybody's speech. The idea of these devices and any kind of alternative output is to simply supplement what someone's not able to say. So again, even when someone is able to say maybe cookie, or you know, goldfish, want goldfish, we can expand upon that. If the child is only able to say, you know, maybe those certain sounds or certain words, we don't want to meet them right there. We want to keep growing them. And so being able to give them alternative means of saying goldfish, like goldfish, please, eat goldfish, more goldfish, please, want goldfish. There are a number of ways to say goldfish that a child can use a communication output for. And so there's also lots of research. There's a research study back in 2004, but as early as 1980, where they showed that babies as young as 6 months could actually use sign language to help them communicate. And again, this is just another alternative means of communication. It's just acknowledging that the system, their body, is not allowing them to say exactly what they want, and we're just giving them alternative means. Again, when you see kids with behaviors, that's a good indication that behaviors that are leading to communication frustrations. It tells me that we're already a little bit behind the ball in terms of helping this child, because they're lashing out in ways that they know best, unfortunately. And that might be through crying, through pulling, through having a fit, whatever that might be. But that's a good reason for us to help them in supplementing what they're not able to say. And again, giving them those alternative means, it just gives them it gives them a better idea of going into a school setting or across environments to be able to communicate for themselves. And so again, providing this as early as possible is going to promote greater development of cognitive skills, language development, social, emotional, and behavior development. Another big myth that a lot of people like to talk about, and we're going to hit this a little bit later too, but the iPad is the answer. And an iPad is a great solution. It's not going to be a great solution for everybody. And again, we'll hit that later. A lot of people go to it because it's very accessible, but it's really, it doesn't necessarily have all the features that maybe some other options do have. And so just keep that in mind, that iPad's not always the answer. Another big one is that a young child is not ready for AAC. Kind of like I was saying already, kids as young as 6 months of age can use sign language. And so again, not to say that that child is, or those children are not going to be able to communicate, but when you're 6 months, your speaking system and your body is not ready to produce sentences and words to the point that that child is satisfied. So again, supplementing, helping them communicate, that's all we're doing until they have that voice or whatever means they need to be able to communicate. This last part is the high-tech AAC is better than low-tech. And when I talk about high-tech, I mean speech output devices. And so these are dynamic screens, such as the iPad, versus low-tech, a lot cheaper options typically. They're static screens, and they might have language boards. Again, low-tech is very important. I provide low-tech, even for my kids who are delayed, who are not necessarily coming to me for assistive technology. I always give them low-tech for the reasons I just listed. in terms of, I don't want them getting frustrated. And for whatever reason, they might be close to getting their speech up and running. But there might be times where they're really just so frustrated that they can't get anything out. So I might provide them a low-tech communication board to help in the meantime. Additionally, with high tech, you're not able to bring high tech everywhere, right? You're not going to bring it to the pool. You might not bring it to the sandbox. You might not bring it to the bathtub for obvious reasons. But ultimately, high tech is also a matter of time before it breaks down, versus low tech with picture symbols, with communication boards, very easy to replace and very easy to replicate. Additionally, if you're out in the community, it's always nice to have low tech boards where you're just going to write to what they want to say. Sometimes with these high tech devices, it might take a little bit of time for them to access that vocabulary for whatever challenge it might be, whether it's their body or whether it's just the overload of the environment. Sometimes low tech is a lot easier to get to. Using low tech will help them get to their language a lot faster. A couple more here was common concern that we'll never understand how to use a communication device. And again, there have been studies for years upon years of kids with very severe disabilities that are able to use AAC and really benefit from them. So really, there are no prerequisites. There are no cognitive deficits that wouldn't be able to use a communication device, which leads me to the final one that I want to cover, and that people always talk about, well, they have to do PECs before they do this, or they have to do this before they do that. And I'm here to tell you that there are no prereqs to using a device, right? And so from a speech therapy standpoint, there are absolutely none. And that is so true. From an insurance standpoint, how much fun and how much we love the insurance, there are some prerequisites for the insurance standpoint. And what they like to see is that a child is reliable in what they say, that they are able to somewhat navigate the device so that they can access and they can get to some of their language. And then that the child is able to understand that they're communicating with the device. And so those can be very, very challenging at times. Usually you're able to you're able to build upon those skills very quickly in giving them the right assessment and really giving them the right tools to communicate. This just makes me think of the iPad. So a lot of people think too, oh, the iPad is going to solve everything. And really, when an iPad is introduced as a toy or a game with YouTube or apps, it's very challenging to go from the iPad to the device. And so it's, again, the understanding that they're communicating through this system. You know, are they looking up when they activate a button? Are they looking for that cause and effect of, if I hit this, I'm going for that, right? That's what we're looking for when we're looking for reliability. And we'll go into that a little bit more as well. So again, take home messages from these common myths. A device will not hinder verbal speech. It'll only improve them. They'll stay stagnant or they'll increase their vocalizations. Low tech can be just as effective as high tech. Absolutely. Everyone has something to say. Very important to remember, because even those kids who are having behavior issues, or they're, oh, the kid says nothing. And I've had plenty of parents that, oh, they don't know anything. Well, just because they can't say anything doesn't mean that they don't know. And, if they're having behaviors, they're trying to communicate the best they can. So again, a lot of this that we're going to hit over and over is that we as providers and we as parents have to play detective quite a bit in order to help them communicate what they're trying to say. Start with what they're already trying to say and move from there. That's how we're going to get them on our end, and that's how we're going to get in on their world. You don't have to wait for a specialist to begin training communication strategies, right? Hopefully you'll be able to take some ideas from today's presentation. Christine has a great one coming up as well, and how to get people ready and how you can implement some AAC. There are no prerequisites to using AAC device, and then it takes time to learn language, right? Language is not learned overnight. And so when looking at assessments for AAC, it's not always a switch that turns for a child. I always explain to my parents that, just because you enter geometry class in high school does not mean you know everything about geometry, right? And so just because you get a device or you you've gotten an AAC system, whether it's high tech or low tech, does not mean that child is competent. Yes, they've heard this language hopefully over and over, but they might not have seen it on the level that they can actually produce it back, right? So the easiest part of this whole process is getting a device. The hardest part is actually implementing it. And that takes time. And so when going into the process, I want everybody to think that Rome is not built overnight and language is not built overnight. And especially for some of our kids who might have alternative or other diagnoses that might interfere with their learning, it means that we have to push that much harder for them to be able to learn certain concepts over and over. Along with that, in taking time to learn language, it's also important to remember that with these devices, it's not just a here you go, or here's the language board, go for it. We have to model this over and over and over. And so research will show that it's about a 4-to-1 ratio on average. Some kids are different. And so what that means is that we are going to model, we're going to comment to them 4 times to 1 question to them, right? Meaning I'm not going to say, okay, show me, show me, show me. I am going to show. And then hopefully I might ask at a basic level for them, I might ask some kind of response back like, hey, did you get that? And that's extremely important. That's a lot of miscommunication on a lot of ends in terms of the implementation of devices and AAC in general, is that we have to model over and over and over for a child to be successful. And I think Christine's going to hit a lot on that later in terms of providing some of those strategies. All right, so AAC evaluation, things to know. Who? Oh, parents. Parents have to be involved. The biggest problem with AAC is device abandonment. The way you fight that when you build upon that is to get the parents on board. Because although teachers and although speech therapists might know this device in and out, or know the child in and out, ultimately it is the parent's decision. And whatever we are putting in their hands, it is in the parents' hands, right? They are in our classroom, they might be in our clinic for a year or 2, and then they're moving on. And so we have to empower parents as much as possible. The one thing I always like to say is that for parents, they know their child way more than we do. And so for them to be successful, for their child to be successful, they need that team behind them to be absolutely supportive and absolutely on the same page to be able to move forward. So other people on that team include the speech therapist, AT specialist, OT, PT, speech teachers, aides, vendors, doctors, everybody. It literally is a village helps the child. Where can assessment be done? Well, so they can be done in the home, not typical, but can be done in home. They can be outpatient clinics in the hospital or school setting. My one thing to really promote here is that if you're doing an assessment outside, in order for it to really be ethical and really to be fair to that child, it's important, and a lot of the insurances actually require this, is to have at least 3 different systems that you're presenting the child. So I've seen a lot of kids that come to me from speech therapists who might have said, oh, well, they're really good at this app. Oh, well, I've heard this app is supposed to be the best one for this population. Put that out the door, because that's not, you're putting your assumptions upon that child. It should be the child leading the way. And so every child has their own features, every child has their own variables. And so we as professionals and parents have to be able to be cognizant of what's going to be fair to that child. Although it might be easy to say, oh, well, this one's what everybody's using, or this one's what the whole classroom is using, that might not necessarily be what that child needs. So keep an open mind, present different systems, present different languages, because it's just important for that child to be able to see, and the parents to see, that there's not just one system, that we didn't just see one system and that's the system we're going with. It's important to know what's out there. And so again, bringing in different vendors is really important as well. This can be done anytime, any way. Anytime a child is frustrated, that's when, again, we should be looking at, maybe there's some alternative ways for them to be able to communicate. Let's try to help them out. And why? Well, this should be pretty obvious, but it's to create independence and to help that child decrease that frustration, and to help them enjoy their lives, and not have so much frustration behind those bodies. So when breaking down this assessment, I love that picture when I found that. It was a little person and puzzle, because I feel like what I love about this job is that each child in each situation is their own little puzzle, in that everybody has their own variables. And it's a matter of figuring out what works for that family, what works out for that team, what works out for that child, what clicks, what doesn't. And I think, and obviously everybody's puzzle is different. And so it's a matter of figuring out, again, what variables fit and what puzzle pieces fit. So background, this is important. This is an ongoing assessment in terms of background. You might have information coming before you see this child, or it might be as you're doing the assessment. So I want you to keep that in mind. But a lot of what I'm going to go over are things that you can find out before they enter your office. So background, assessment, and then recommendations. So AAC background, diagnoses. This is a huge one. So a lot of people just look at the primary and they say, oh, well, the child has this, or the child has that. But a lot of times there's something else going on, and it might not be diagnosed. What's important to know about this is that the date of the onset. So if they had an injury, like a head injury, or if they had any kind of cochlear implant, when was that implemented? How early? What kind of language have they been exposed to? That's going to be a really good idea of what prognosis we should be expecting in order to move forward. Medical history, seizures, surgeries, Botox, medications, those all impact a child's performance. And so when I'm thinking about seizures, I'm looking at, well, how many seizures does a child have? Are they tired after they have a seizure? Do they regress in any way? How about surgeries? Do we have any surgeries coming up? Do we have, is their tone going to change with any kind of Botox or medications? Medications can definitely impact sometimes your retinas in your eyes. So for example, oh shoot, I can't even think of the one now, but there's one that I think it's baclofen. If you have enough baclofen, that it will actually impact your retinas and how wide your retinas get. And so it impacts an eye gaze system. Just keep that in mind. It does take a lot, but just something to keep in mind. For current and past therapies, I definitely want to know this. What type of symbol repertoire does the child have? Any exposure to AAC, therapist understanding of AAC, resources from school? These are all huge, because again, it tells me more about that child's team. What are they coming in with? What do they have an understanding of? Because you never want to forfeit any kind of learning. And so if a child has an understanding of symbol sticks or PCS symbols, I want to use that to our advantage. I don't want to start from scratch. I want to use what that child's already using or has been exposed to. So if they come in with any kind of device, I'm going to start with that. Or if their speech therapist or parent has introduced any kind of system to them, I'm going to see what they already know. What have they learned? So that's all good and well. Residents and team, again, I hit on this over and over. What are they going to need in each environment, right? In the school setting, when you do a school assessment, it might look different than an outpatient or hospital evaluation, because in a school setting, you might be looking more at academics, versus in a hospital or an outpatient setting, you might be looking at the more broader scale for that child in terms of what their home life looks like. Do they stay with a consistent caregiver? Are they going between homes? Are they staying with caregivers who might not be they might not be device or technologically savvy? These are things that we need to figure out. How often are they being able to be exposed to these symbols and into language in general? Are they coming home after a full day of school or ABA and just going right to bed? What is the team capable of? Because again, this child's only going to get so far. That team has to be supportive in order for that child to get anywhere. Is everyone on the same page? I've had tons of families where maybe one parent is on board and the other it's kind of on the other parent. And really that's going to be a hindrance to the child. And so we have to know that. We have to empower parents in order to get everybody on the same playing field so that child can go as far as they want. other competing programs or things in place, so again, are they going to ABA all day? How are we using it? How are we implementing it? What does language look like in this child's day? This is a great picture. I love this picture. This is kind of what goes through my head. Might sound a little crazy, but many things go through my head. But in general, this is kind of the idea. I look at the whole child in terms of their receptive skills, their communication skills, their hearing, all their access modifications, their fine motor, their gross motor. This is kind of a nice overlook. This is a really nice handout that one could print out. And it's what I keep in my head as I go on here. So going into that, digging a little bit more, vision, acuity, and field cuts. Sometimes these are not diagnosed. I've had a lot of kids that come in with CVI, cortical visual impairment. I recently had a kid who was only pointing to things on his left side. And so nothing was diagnosed. He came in as a child with autism, and as far as we knew, mom said, vision is fine, good and dandy. And we come to find out that, we keep going to the left side. And so we put preferred things on the right side. And we began to notice a pattern of he's only going to the left side. And it was only when it was down. I want to say it was left and down. And so we did an informal assessment of his eyes and come to find out that there were some visual cuts. And we did refer them. I mean, I can't say that, but informally I can say that. And so we sent them to an ophthalmologist, which can be helpful, but I always like to see them go to a neuro-ophthalmologist who looks a little bit more at the brain. And so what that brain might be seeing. And there's tons of research on CVI out there. But CVI is something that, again, an ophthalmologist might not be able to diagnose because, again, structure-wise, your brain, your eyes look fine, but CVI is somewhere along the cortical visual tract that there's a disruption. And so there might be inflammation, there might be damage to that tract somewhere, but it's not always going to be seen on a brain scan. And so you're looking at a lot of different clues that, colors and what they're looking at, how they're looking at items. That's something that you can get a lot of information on. Hearing. What level are they hearing? This is extremely important because, again, if they are not hearing me at all, then is it a matter of, I need to know what they are hearing, because if I am saying something to them, and they're not following, is it that they don't understand? Is it that the language is too complex? Or is it something else? Maybe that they just don't understand. And so that's really important to know. When did they get their cochlear implant? Hearing aids, do they keep those on all day? How does it all work? How does the child do on a typical day? Sensory, anything impacting the use of technology? Do they stim? Do seizures come about if the screen's flickering? Do they perseverate on buttons? These are things that are going to impact my ability to help this child in terms of being successful. Physical. So everything here on this page, I like to always refer to my occupational therapist or physical therapist, especially for the physical part. Can they isolate a finger? Do they need support? Do they need a key guard? Do they need a touch guide? What's their range of motion like? What's their endurance? What's their strength? And so the idea of this is that, how big is that system going to be? Are they going to be able to carry it around? Are they going to be able to access that language all by themselves? Because the most important part of all of this is that we have access, right? You can have all the language in the world, but if you can't get to it, it's no good. And so we need to make sure that we have a good idea of how they're going to get to it. Again, once they come into the evaluation, then we'll have a better idea of what the child can actually do. Cognition. So before a child comes into my office, I always like to get an IEP or any kind of speech notes. I want to know what they're interested in. How do they interact with objects? Again, these are going to give me an idea of what age level they're cognitively at. Additionally, with what is their understanding of communication? Some parents will say that the child only comes to me when they want something. Pretty typical. Early language skills, so that's fine. Attention and memory, those are huge. I talk big about that in terms of final recommendations, because attention and memory don't change overnight at all. Sometimes attention can change in terms of motivation, but in general, if they're a busy body, that's a challenging barrier. But again, we'll face that. And then the receptive expressive language skills, extremely important to know. Again, you have to know what that child understands. And hopefully we get a good idea of what their receptive language is prior to them coming in. So I always like to see a receptive vocabulary test or receptive language test in order to have an idea of who that child is stepping into my office. Additionally, it's always good to have that information because it gives us good ammunition when we're going to insurance to say, hey, this kid knows this much and it's a formal test and they're communicating at this level. So we need to fill that gap. I mean, you can't argue with actual data, and that's what we should be using, is some form of data. So again, any good questions, formal assessments, informal assessments, I'll get into that in a second. All those are really good information to have before a child gets in your office. All right, so during the assessment, so let's say the child is now in your office. And so biggest thing is positioning. A lot of this I will look to my OT for if they have difficulty in accessing the language. Positioning is important, just like lifting weights. So it's going to be extremely hard if you are slumped back and you are trying to lift weights. You have to engage your core quite a bit, versus if you have good seating, good posture. If you're in a wheelchair, I want to make sure that your butt is against the back of the chair. If you have shoulder straps, I want those on. I do not want them loose, because again, if they're loose, you're out here. And again, just think about it. If your feet or if your body was out here and you're trying to lift, you're not using your diaphragm very well. You're not using your abs very well. You're not engaging your middle section. Same idea as I want to make sure that that child's feet are planted in the ground. Again, same thing. When you lift your feet and you try to lift weights, much harder. If you really want a good core workout, lift weights while lifting your feet. You're welcome. Motor assessment. So again, access is everything. Before we get to language, we need that access point. How are they going to get to that device? Are they going to be using their pointer finger? Are they going to be using a hand? Are they going to be using eyes? Are they going to be using a switch? Where is that switch going to go? And that's a whole nother talk. But essentially what you're looking for there is what is the easiest and most replicable movement for that child. Doesn't matter where it is on the body, we can find a switch for it, but you need to find out what's the easiest and most repeatable movement for that child. And so visual motor, visual attending, how quickly do they look at it? Do they look from the side? How big do we need to have these symbols? That's what we're looking for. And there's some assessments we're going to go into in a little bit to figure out, to give you an idea of that. Type of display, is it going to be dynamic? Are the screens going to be changing? Is that overstimulating for the kid? Presentation of display, so is it going to be upright or is it going to be on the table? You know, if a child has visual cuts, on the table might be too much. If it's presented to the right, it might be too much. If it's upright and a child has really low tone and really poor strength, they might not be able to get up here and lift their arm up in their shoulder socket to get everything up here. So we might have something supported under them. Validating language abilities. So again, although we got all those assessments before they came in, I want to make sure I'm going to grill parents pretty good in terms of getting a good idea of what they're seeing at home and what their understanding of that child is. I've learned this over the years that you have to ask really good questions and ask them in different ways. Really make sure you know what that child can do and can't do so that you have some validity, because this all takes, we need to know that they're doing it with some kind of validity. One of the best questions to ask is, how do they show you that they like something? This seems like an obvious question, but some kids, you know, they will smile or they'll laugh or they'll chuckle or they'll do something to give you some kind of idea of, all right, I'm on the right track. But that's the most important part. because a lot of parents come in saying, oh, well, they know pictures and they touch that picture and they know what they want. And it's like, well, are they touching that picture because they know a cause and effect? Or are they touching that picture because they know of an association, right? And so that's a big thing that a lot of people forget to do in PECs, is that, and is a big part of this assessment, is validating responses. And so when I do that, I'm going to present 2 different pictures. And I'm going to, as soon as they make a choice, whether it's pictures, objects, whatever it is, I'm going to then make sure that what they say is associated with what they understand it means, right? So if they say goldfish, I'm going to say, okay, go get it. What did you ask for? And so I'm not saying go get goldfish. Where's the goldfish? I'm not telling them what to get, because I want them to understand that what they're looking for, they should understand what they're looking for, right? So I'm assessing whether they understand what they just asked for. Do you understand that you just touched goldfish? So let me repeat that again. So if they touch goldfish, I'm going to show them the objects, and I'm going to say, go get it. Or what did you ask for? In that way, they're showing us that they understand that that goldfish represents the item, that goldfish. If they reach for the other one, I'm going to 3 steps here. I'm going to 1, not give it to them. I'm 2, going to teach them. So I'm going to say, oh, well, if you want Cheez-It, this is Cheez-It. I'm going to associate that picture with what represents that item. And then step 3, I'm going to represent the pictures or the symbols, whatever it might be, on whatever platform it is. We'll get into that a little bit more as we go here. So again, the assessments have to know what they understand. Formal assessments, definitely a great idea. Some kids will not be able to go through that. And so receptive language, I just had a kid who was hard of hearing, and he knew lots of sign language, and was only using one word utterances himself through sign language, but really wasn't very independent by himself. He really depended upon his mom, but mom translated the whole test back to him so that he was able to actually point to the ones that were accurate to what he knew. Obviously, you can't make, it's no longer a formal assessment because sign language doesn't always translate exactly. And so, or at least to this mother's extent, to what she knew, which was totally fine. She got way more than I did. And so having an idea of what that child's receptive vocabulary is and receptive language, that's going to be huge for where we start and what we present. And so if we have an understanding of what's receptively where someone's at, you can get somewhat of an idea of expressively where they should also be at. Not necessarily what they're doing, but what they should know. And so receptive vocabulary, I like the PVVT, the receptive one word, very quick and easy. The expressive one word, I might use that. It really depends on how verbal the child is. Sometimes they're not able to participate. And again, it's still good evidence for us to say to insurance, hey, they can't participate in that. That's how severe their speech is. Receptive language, tackle, Tony, owls, early communication emergence language. I usually use the owls because it gives me good language and it's quick. Tackle is also very good. And then informal assessments. This is probably, I use this the most. So holding up objects and pictures up in a field of 2 to 5. I might have a clear board, and I've adapted some of the tests, like I've adapted the tackle test where I put 4 on the board so you can use it as a visual test instead of just maybe they can't point. And so they're looking at what they want. The owls, that I find that to be a great test. Oh, sorry, I skipped. Yeah, so when I'm holding up the assessments, I'm looking up at the categorization, attributes, functions of objects, literacy if I need it. Do they recognize words? What kind of symbols? And then I'm looking at grammar. All right, so at during the assessment, I'm going to look at this is the one that I was thinking of earlier, is the AAC Genie. That can be found on the iPad. I don't know if it's free anymore, But that's a really helpful test, and that will help you understand what they're able to do in terms of their isolated finger. Those other ones, the communication matrix is free. You can get that online. That can be helpful. That's more of a long-term, like if you have more time. Usually in my assessments, it's about 3 hours. And so I don't typically go through that. I go through it in my head. But I definitely do include the AAC Genie. That's pretty easy to get through. And you don't have to present all the different areas. And then the important part is, do they recognize pictures? So it kind of goes from real to abstract. These are some of the symbols that I have on the board here. So PCS symbols that's made in Boardmaker, those are very common. Symbol sticks, those are often found in on language apps on the iPad. The MinSpeak symbols, those can be complicated for some, but they can be very, very, very good for others. And they mean different items. Types. So I want to know, again, what kind of pictures do they understand? Do they understand real pictures? How are we going to do with verbs? Because in order to navigate on a device, we have to have an idea of how they're going to go together. And so can we get to the goldfish under eat, or do we have to make moves elsewhere? Number. So number of options I usually give them. I start with 2 or so on a screen or with picture symbols, and I move from there. In size or configuration. So again, are they going to be able to hold it? Are we planning on them holding it? How are they going to access it? Can they do it consistently? All right, and then when choosing vocabulary. So we have to play detective. And so we have to say, we have to pretend that we're the child. And so what are they motivated by? This is what I said earlier, is that we have to play detective. And so what's motivating that child? What are they reaching for? What are they pulling you to? Start there. And do you want the goldfish or do you want the Cheez-It? Oftentimes food is very motivating for them. How do they confirm that? And so again, the golden rule, the motivation must exceed the effort. Because again, if it's not worth it to them, then they're not going to do that. I'm not going to force them to communicate anything that they don't want to say. I'm going to wait for them to initiate. And so again, wait for them to pull you, to show you what you want. Usually they'll be reaching for what they want. Set that child up for success. So again, sometimes just presenting picture symbols is going to help them. Sometimes it's not, and we just move right to the device. You only need to have 2 symbols per page. And the biggest thing is modeling the use of AAC. Again, like I said earlier, we don't want to just give them the device or the picture symbols and assume they know how to use it. I'm going to show them, oh, eat goldfish. Oh, here's a goldfish. I get to eat goldfish. And for kids with hearing impairments, it's very important to give them that idea that there is that not only cause and effect, because we're not necessarily teaching cause and effect, we're also teaching that association that, oh, if I touch goldfish, I get goldfish. But if I touch Cheez-It, I get Cheez-It. It's not just a matter of I touch something, I get what I want. It's a teaching association. So that's a big, big part. That's why we do the reliability. So we're not just teaching a cause and effect. Presenting that object after they choose a symbol, got to make sure. Again, make sure that child shows that interest. That's where you want to start. Final recommendations. So the biggest thing is matching the child's features to a device. So for a lot of those kids with hearing impairments, highlighting, color coding, those can be very, very, very helpful. Any kind of prediction, camera, navigation, how are they doing that? What kind of language is the child using? Are they using more core vocabulary or are they using more fringe vocabulary? Again, there's a lot out there about core vocabulary, but it's not appropriate for every kid. Some kids don't care about some of that vocabulary, and we need to build on what they already are telling us. And so starting with that fringe vocabulary is a-okay. Child's attention span. So I talk about this a lot because, again, if a child is a busybody, I don't expect them to sit there and go through 9 hits to get to 2 words or whatever they want to say. So I'm going to provide them something very quick to get their buy-in. You need that child's buy-in, meaning they get what you are selling them, for them to be successful. And so then I'm going to ask, we're going to talk about the communication bids and what the child's trying to communicate. once we get their ability to, once we get to the end of the session, we've kind of presented 3 different devices. I'm going to look at the team and see how we're feeling. What are their thoughts? Do we have enough data to make a decision? If not, that's okay. We can always go on and get more data, and I'll go over that a little bit. I know I'm running out of time, and the dog is looking to get out. And so financial implications, insurance usually covers about 80% of these devices. And so when you're talking about a speech device that could be $6,000, it's $1,200 coming out of pocket for the child. And so we want to make sure that we're setting the team up for success as well. This is a really nice chart that Vicki Clark out of Dynamic Therapy Associates created. And it talks about some of those commonly used devices and some of those features that a child might need in order to be successful. And this is usually what goes through my head and what parents and I discuss in terms of picking a device. And so we'll go through that. Of course, you can make your own, and every child has their own, and that some features might be important and some features might not. But it's important to know that not one device fits all, and you need to start with the child and what they understand, then match that to a device. This is on iPads versus dedicated devices. And so usually we don't recommend iPads just because durability, volume, tech support, resources, symbols, access, it doesn't have a lot as much to offer compared to those dedicated devices that can be $6,000. Now again, $1,200 out of pocket for a family, that's a lot of money. So we might look at an iPad that time. But again, it kind of depends on the child and what they need. So recommendations, wrapping up. Once we figure out the device, it usually takes about 3 to 4 months until that device arrives. So we want to think about the short-term plan. What are they going to use until that device gets there? This is where low tech comes in. And so having that in place is going to help them be that much more ready when the device arrives. So I might do screenshots. Each of the devices, they all have websites where you can download things to help them get ready. A trial period if they need it. Training if the child's not ready, they can come in, or we can get them necessary projects and programs to get them ready. Long-term and short-term goals, that's when we decide those, what's going to be appropriate for the next 3 months, and then next outlook is 6 months. All right. What happens when the device arrives? Most important part is make sure you get that device set up. So go back to that speech therapist who made the recommendations, because they are going to have to give you, they have an idea of where your child's going to be at. And they also know what equipment was being ordered. So if you wait too long, that equipment might not be able to be returned, or you might have to then pay out of pocket for additional equipment. And so we don't want that to happen. So make sure you go back to your speech therapist to do the follow-up recommendations. You're going to customize at that point. Parents are going to get empowered. So therapists should be showing you how to take pictures, edit, hide, show, do all that kind of good stuff to make that child ready. Because just like our phones, nothing comes out of the box ready to go. And we need to customize these devices in order for these children to be successful. Setting up the team for success, and everyone has a job. I always like to give parents one activity to do, figure out a time that child is very successful, and be able to allow them to focus on that one activity for that next week or two. And then for the following week, we can think about a different activity that they are highly motivated by that might happen every day that they can also focus on. But it's really important for the parents to go home and work on that device by themselves. So when the child goes to sleep, and know where language is in order to be successful in teaching that child. Because the only way you're going to be a good teacher is by learning the material yourself. So you can't just rely on the kid to do it. Utilizing the resources. Here are some of those resources. So practicalaac.org. These are all really, really good. That practicalaac.org has a really nice blog, a lot of great information out there. Printy Romic Company. These are some really good organizations. And last but not least, no one ever rose to lower expectations. Keep that in mind as you move forward and work with these individuals. Thank you, guys.
Thank you. That was awesome.
Thank
I
you,
know, sorry, I put
Jason.
so much in there.
You did have a lot of information. It was packed full, and I love it. We do have a question or two. So Nikki, can you read?
Yes, we have one question. Is severe apraxia something that AAC is recommended for as young as 2.5 years old?
Yeah, absolutely. Again, apraxia, there's a whole spectrum of it, and it's not something that's fixed overnight. So again, we're going to look at supplementing what they're not able to say. I have tons of kids with apraxia speech, and again, they might speak, you know, they might have some multiple word sentences that they can get out, and that's great. We're gonna want speech as long as we can, but we're gonna decrease that frustration as soon as possible with some alternative means.
Okay, we have a question here too. For people that are outside the Metro Atlanta area, where could they find services? And do you all do virtual?
So at Children's, we do not do virtual, unfortunately. But in terms of your area, you can look at your local university. Usually they have a program, a local children's hospital does. But the easiest thing you can do too is go to one of those websites. So the Parent Enrollment Company or Toby Dynavox, and ask where recommendations are coming from. Usually it's hard to find them in the communities because the paperwork takes a long time and all that. So I would go to your local reps or local university and just search AAC recommendations in my area.
Thank
We have
you.
one- Nikki said we have one more question.
Yes, we have one more question. It says, in a bilingual context, do you introduce either L1 or L2 with the picture?
You can do either. Research has shown that using bilingual language will actually help and increase a child's understanding of language versus just doing one route. There's no need to do one over the other. So pick one or pick both, and you can go with it.
Great.
Thank you so much, Jason. Yes,
guys
our
are welcome.
time
There's
is
my
up,
email at the
and we
bottom.
really appreciate it.
Yeah, I know you mentioned yesterday that you were in like in the middle of a move or something too. And so I'm really like,
Yeah,
the fact that you gave us that time is awesome.
Thank you.
absolutely. Glad to be here. Thank you, guys.
So
Okay.
we're gonna ask you to stop sharing,
Okay.
and then